So hi guys, today in this video from the Otorhinolaryngology series, we are going to cover Otitis externa. But before covering Otitis externa, we need to understand about the anatomy of external auditory canal. So we will start it with first. So clinical anatomy and diseases of external auditory canal. What is the embryology behind it? That external auditory canal is like this. I'll show. First, it's upward, backward and medial, and then downward, forward and medial, and this is what is known as the external acoustic meatus. So develop from the first pharyngeal cleft, cartilaginous part is present at birth and bony part will develop later. Anatomy proper and applied aspects. Length being 24 mm of the entire external auditory canal, divided into two parts. Cartilaginous part, which is lateral 1/3 is of 8 mm, and bony part medial 2/3 is of 16 mm. Then what is note is function of external auditory canal is transmission of sound to tympanic membrane. Thus the cartilaginous part is how it's upward, backward and medial. Important to know is the cartilaginous part is basically consists of lining epithelium, which there is a skin, there are hair follicles, there are ceruminous gland. Skin, there is a stratified squamous keratinized epithelium. Hair follicle, furuncle, folliculitis is seen only in cartilaginous part, and ceruminous gland will secrete the earwax, that is apocrine gland. Then what is features of Santorini? Cartilaginous part के floor पे there are deficiencies. Those deficiencies are present anteroinferiorly, which are known as features of Santorini. And through these features, the infection can spread to parotid to cause parotitis and base of skull to cause cranial nerve involvement. Next is parotid swellings can bulge into external auditory canal through these features. Next is bony part. Bony part is directed downward, forward and medially, and lining epithelium is thin skin, which is stratified squamous keratinized epithelium, and there are no appendages which are present in case of a bony part. Isthmus is the narrowest part. It is the part basically which provides functional physiological barrier to protect the tympanic membrane, the umbrella-like tympanic membrane, and significance is foreign body impaction. Surgical instrumentation is necessary for its removal. Next is anterior meatal recess. See, this is how goes the external auditory canal, tympanic membrane, and from here starts the middle ear, and there is the internal ear. So middle ear, whatever discharge is there, that travels through this tympanic membrane and it pulls up. This is the narrowest part, and this narrowest part is basically called the isthmus, is what just 5 to 6 mm lateral to the tympanic membrane. Just lateral to tympanic membrane here is basically what we call as isthmus, and discharge and just behind the isthmus is the anterior meatal recess where the discharge from the middle ear pulls. Next is foramina fuscae. Foramina fuscae is basically deficiencies in the floor of the bony part, and it closes as the external auditory canal grows and spreads. Infection is important. So how to visualize the tympanic membrane? This is the tympanic membrane, as I told. This is the pinna. This is what? This is the cartilaginous part, which is upward, backward and medial. And what is this? This is the bony part, which is downward, forward and medial. It composed of a skin, hair, follicles, ceruminous glands. Folliculitis is common. Furuncles are common over here. Here there are no such appendages, only a skin, which is lined by stratified squamous keratinized epithelium. Now talking about again how to examine it. So external auditory canal, as you see, it is a bent structure. If you want to straighten it in adult, you need to pull it posteriorly plus superiorly, and in infant you need to pull it backwards and inferiorly. So that's very important. Yes, and yeah, because bony part is absent, as we discussed, that cartilaginous part is present since birth and bony part develops after birth. So in children mostly bony part is absent, and the tympanic membrane nearly horizontal and the tympanic membrane is present inferiorly, as you can guys see in this diagram. This is the external auditory meatus, you can see, and then as you can see, this is the what we call as a external auditory canal, and what you can see over here is the tympanic membrane. This place, tympanic membrane, that's a tympanic membrane, and it's present quite inferiorly. So the position, that how we should examine the external auditory canal, is different in this case. Now talking about the diseases of external auditory canal. Guys, now talking about diseases of external auditory canal, what the main complaints a patient complains of, that is the pain and the discharge. Pain and the discharge are always seen as a complaints of internal ear and middle ear, but not the inner ear. Why? Because inner ear has no sensory nerve supply. Therefore, any kind of pain won't be even feel. So that's why inner ear there is no complaint. Just limited to external ear and middle ear. Talking about otitis externa. Otitis externa is a term which is used for infection of external auditory canal. What are the causes? 90% of the cause is bacterial cause. Then we have fungal and viral causes too. Then we have furuncles. What are furuncles? Furuncles are basically the hair, and localized on examination causative organism is Staphylococcus aureus for the furuncle. Clinical features for furuncle basically it presents with a pain with or without discharge, purulent, and pain in the ear on jaw movement. What is TMJ movement? Whenever we open the jaw, the temporomandibular joint will impinge upon the cartilaginous part of the external auditory canal, and this will basically cause the pain. That's the relation. So what is this helps? Tragus sign. What is tragus sign? First we need to put a pressure on tragus. After putting a pressure on tragus, if the external auditory canal will basically feel the pressure, it will pain, and maybe discharge will also come. And if these two signs are absent, then we can rule out the involvement of the external auditory canal. That is, if pain occurs, then of course there is an involvement of the external auditory canal, and if the pain doesn't occur, then we can understand that it's a referred pain. So it's basically to rule out the referred pain and pain at external auditory canal. Now we'll discuss about the other things. Examination. Okay, so discuss about the other thing, that is what we have is an examination. But how to perform the examination, triggers and that all is done. Talking about the management. In management, what we have is first we'll give the antibiotics. Antibiotics we can give plus or minus 1 ND, and what we can also give is known as a 10% of the ixtamol glycerin. What is ixtamol glycerin? Ixtamol glycerin basically what? Ixtamol is an antiseptic, and what we have is glycerin is known as basically a hygroscopic. So ixtamol and glycerin antiseptic and hygroscopic, and if still after this treatment also it's completely like multiple time it's recurrent, then we can say we have to need to rule out a diabetes, to rule out a diabetic condition. So what we now we're going to discuss is the swimmer's ear. Swimmer's ear is basically a condition which is caused because of the organism known as Pseudomonas. Again, Pseudomonas being the most common organism which causes a swimmer's ear. Swimmer's ear occurs always in a IC patient, not immunocompromised but immunocompetent patient it occurs. What are the deformities which we can see? In swimmer's ear, what exactly occurs is the etiopathogenesis. First, there we can see there is a itching, then there occurs an abrasion, and following the itching and abrasion, there cause basically the infection, and this is seen in immunocompetent individuals. Causative organism basically Pseudomonas. What are the clinical features the patient complains of? So clinical features the patient complaint are of two. What is basically pain? Pain is basically with or without discharge, any kind of thing, and pain in ear on joint movement. This is the one of the complaint, very important. Then what are the examination? On examination we see two things. First thing we see is the diffuse edema. There is a diffuse edema present, and this diffuse edema present of external auditory canal. And second what we see is a tragus sign positive. There is basically a tragus sign which is positive. Here the tragus sign positive in this case of swimmer's ear is not actually diagnostic in nature. It's not, but still it's indicative, not diagnostic, but still we can consider that it's indicative in nature. Now discussing about its management. Management we can give is by oral toilet. What is oral toilet? And then we have to give the ciprofloxacin. Ciprofloxacin we can give in both ways. We can give in local way plus systemic way, in both ways. What is this? Malignant on examination or skull base, malignant otitis externa or skull base osteomyelitis. Second condition we are going to discuss is basically the malignant otitis externa, or we can also call it as a skull base osteomyelitis. What's the osteopathogenesis? Most common organism involved is again the Pseudomonas. Pseudomonas is the most common organism involved, and it is basically seen in what? This condition is normally seen in immunocompromised patient. That is, most common cause of this is being the diabetes mellitus. Mimics what? Malignancy. So it mimics the malignancy in nature and can spread to base of skulls via fissure of Santorini, and it can lead to skull based osteomyelitis. So pathogenesis of malignant osteotis externa to skull based osteomyelitis is basically, it will mimic the malignancy and it will spread to the base of skulls via the fissures of Santorini. Via what? Fissures of Santorini. Then what are the clinical features? Clinical features being elderly and severe excruciating pain is present. What is that? Severe excruciating pain plus discharge, and it is present in elderly. And on examination, what we find? On examination we find two things: necrosis and granulation. These are two things which we find on examination. Talking about investigations, in investigation what is important is that TC99 bone scan. This is more discussed in detail in radiology, but TC99 bone scan will cause the basically increased uptake of TC99. Increased uptake is a early diagnosis, and CT scan only shows erosion after they have occurred, not during the process. But this TC99 bone scan is very important for. So guys, talking about, we did till the CT scan, which can only detect the changes after erosion, and what is important is this gallium or indium scan resolution for hearing. Treatment: oral ciprofloxacin for 6 weeks, some parenteral ceftazidime, cefperazone, and newer penicillin like piperacillin and ticarcillin. Then what we have is the complications: base of skull, cranial nerve 7, 9, 10, 11. 7 is the most common nerve which is involved. Next we'll do the otomycosis. Otomycosis, most common organism for otomycosis is known as basically the Aspergillus niger. The second most common organism involved for otomycosis is known as Candida. So what are the clinical features of otomycosis? Again, the clinical features being the same, that is the pain with discharge. This is the important clinical feature which present with, and on examination Aspergillus niger will give a wet newspaper appearance, and Candida will of course what? Guess what? It's the cotton ball appearance. Management against remains the same, that is oral toilet. So oral toilet can be given for management, and then we can proceed with the local antifungals. Local antifungal ear drop. Our next topic we are gonna see is the herpes zoster oticus. What is it? That's the herpes zoster oticus. What is it? It's the viral Otitis externa, and what is important is common organism is against, as the word suggests, varicella zoster virus being the common organism. And what is the clinical feature? That's the pain, and on examination what we find are the vesicles. And management, what is the management is basically diagnosis is again this herpes zoster oticus. Management being antivirals. We can give antivirals, but we can also give a short course of steroids in this. Next what we have is a Ramsay-Hunt syndrome. What is Ramsay-Hunt syndrome? Ramsay-Hunt syndrome is basically herpes zoster oticus plus facial palsy, reactivation of herpes zoster in geniculate ganglion of the facial nerve, and also facial nerve palsy. Next is wax ceruminous gland secretion. Clinical feature of wax being blocked ear and pain being present or absent. So how to manage wax? Very important, because wax is a very important topic. What is wax? It lead to basically a blocked ear, and also it may cause basically to pain to be present or absent. Now talking about the management of wax. In management of wax, it is cleaned only if impacted. By how we can manage it? We use the wax solvent, and it calls the oral syringing. What is it? Oral syringing. How is oral syringing for a serious diagram? So what we do, first thing is that the temperature is what we're gonna select is the body temperature, and hot and cold water will stimulate the internal ear by convection. So what is the thing is, hot currents will basically cause vertigo. Direction is postero-superior. Complication, perforation, vertigo, infection. Contraindication, existing perforation, and battery. This battery can cause basically the necrosis or leakage. So what are the instruments used? Those are basically Johnson's horn probe with a ring curate. Can you see? This is Johnson's, and this is the forceps for impending wax removal. Johnson's horn probe being important. Next, what we have is a keratotis obturans. What is keratotis obturans? As you can see in this diagram clearly, it's basically abnormal epithelial migration will cause a collection of desquamated epithelium, that is in onion skin pattern, and this desquamated epithelium will cause the impaction. This impaction will lead to dilatation of external auditory canal, ulceration, and severe pain. And what is important? Examination: wax is seen covering the mass and widened canal. Which mass? This mass, that is the desquamated epithelium mass, as the onion skin pattern. Wax is seen covering it, and this all wax plus this desquamated onion skin pattern will cause impaction, ulceration, dilatation of EAC, and it will lead to severe pain. So widened canal, how is the management of it? Management is basically important is removal of the instrumentation through with decreased local anesthesia and general anesthesia. This is C. Desquamated max covered with wax and onion skin pattern appearance. What are the association it? Due to abnormal cilia, sinusitis and bronchiectasis. And what is the complication is 7th cranial nerve palsy. So yes guys, that was about otitis externa, external auditory canal disorders completely. Thank you so much.